All right, welcome back, everyone. Welcome. We are about to continue on with our conference. We are so excited. So I will invite you to our next general presentation. All right, this next general session is so exciting. This session is sponsored by the Henry Ford Comprehensive Epilepsy Program and is entitled Demystifying Brain Surgery from Process to Procedure. My name is Renee Roederer. I have had the pleasure to know many of you, but if we have not met before, I serve as the Community Care Director from the Epilepsy Foundation of Michigan, and I have the absolute honor of facilitating this next session and, of course, welcoming our wonderful speakers. So here to present on this topic are Dr. Ellen Eyre, neurosurgeon, Dr. Jamal Khattak, adult epileptologist, and Dr. Jules Constantino, pediatric epileptologist, all from Henry Ford Comprehensive Epilepsy Center. Please join me in welcoming them. A very warm welcome to all three of you. I'm so glad that you're here today. And I'm wondering if you can start briefly by sharing a bit about your experience with this topic and its interest to you.
Sure. So again, I'm Ellen Eyre, and I am a neurosurgeon. I am trained in what we call stereotactic and functional neurosurgery, which includes epilepsy. So that includes the broad span of surgeries such as removing pieces of tissue for the treatment of epilepsy, as well as use of electrical stimulation and lasers and other modalities to treat epilepsy. And I've been in practice about a decade.
So I'm Jamal Khattak. I'm one of the epileptologists. So very early in my neurology residency training, I got interested in epilepsy as I found it very interesting and intellectually stimulating. And I recognized that this is one of the few neurological diseases that we actually have a cure. So I pursued 2 years of epilepsy fellowship training and did an extra year specifically to become more proficient in surgical epilepsy. And I had been part of Henry Ford Health for the past 2.5 years, where we evaluate patients with complex epilepsy and try to figure out what's the best treatment options for them and surgical options.
So I'm Jules Constantino. So going back a long time, I was in my pediatric residency training, and I was thinking what sort of subspecialty did I want to do, and was it going to be pediatric gastro or pediatric diabetes or maybe pediatric neurology. And so I said to one of my mentors, I said, well, I'm thinking about pediatric neurology, but can you actually help anybody? And I got this look, and he shook his head and sent me to Boston Children's Hospital, where I did a fellowship in epilepsy. And I remember coming back from Boston to West Australia, where I'd done my initial pediatric and neurology training. We were able to set up facilities for epilepsy surgery for the first time. And I remember our first 2 cases. And epilepsy surgery, is not for everybody, but I think a lot of people can benefit. But the first 2 children we did, one was a young lady. She was about 14 or 15, and on her MRI, she had a hippocampal sclerosis, and she did very well after surgery, became seizure-free. And there's another boy that I'll never forget. He was about 15 or 16. He had a congenital hemiplegia type of CP, that is cerebral palsy, that he was born with. And on his MRI, he had a large destructive lesion of one hemisphere. And we did what we called what's called a modified hemispherectomy, where you disconnect half the brain. And again, Paul did very well. And I remember him coming back to the clinic, and his life was changed, and his family's life was changed. And he was, and this is important in Australia, he was like, I can go to the beach and I'm sure I'm not going to have a seizure. And I think impressions like that never leave you, and they stay with you. And I think that's why we all do this.
Thank you. I know that you make such a big impact on all of us as patients and community, and it's so lovely to hear stories of how they have impacted you as well. So I'd love to begin with a question for you, Dr. Katak, and also Dr. Constantino. We know that anti-seizure medications are the first-line treatment for people with epilepsy, but of course, unfortunately, some people have drug-resistant epilepsy. Under what conditions would you begin an evaluation to see if a patient might be a good candidate for epilepsy surgery?
So as you said, when someone is diagnosed with epilepsy, the first line of treatment are the anti-seizure medications. And I always tell my patients that the first anti-seizure medication has the highest chance of achieving seizure freedom. And different studies have shown that around 50% of people become seizure-free with the very first medication. Once someone fails the first anti-seizure medication, then the chances of the second medication stopping the seizures are much less. And different studies have shown different numbers, but around 20%. And 1/3 of people do not respond to two seizure medication. And that's when we call it drug-resistant epilepsy. And that's when we talk about surgical workup, meaning to achieve seizure freedom, further medication trials have a very low likelihood of achieving that. So if we consider the prevalence of epilepsy in the United States, there are 3 million people around who have epilepsy. So around 1 million people are drug resistant, and that's when we consider surgical workup.
So thank you, Jamal. So just to expand on that, how many people with epilepsy in the United States?
3 million plus.
3 million. And of those, how many are children? 500,000. So probably there's estimates that it's actually 470,000 children with epilepsy in the United States. And of those, perhaps about 26% or about a quarter do have drug-resistant or intractable epilepsy. So we can recognize drug-resistant epilepsy fairly early, in the sense that we know that as Dr. Katak said, was that if you're still having seizures after a trial of 2 medications, and these are seizure medications which are of good dose and of good choice. And what does that mean? It means that the medication is appropriate for your seizure type. So if you have a type of epilepsy that's juvenile myoclonic epilepsy, and if you go on a Dilantin or Tegretol, that's not the right medication for you. It's not going to make you seizure free. And then the other side of the coin is the good dose bit. Sometimes I'll put you on a little smidgen of trileptal, and you'll come back and say, Doc, I don't know what you did to me, but I'm just groggy and I'm sleepy and I can't walk straight and I'm seeing double. And I'm like, well, I only gave you a little pinch of it. But some people can, as you all know, can be sensitive to certain medications. But certainly, if we're still seeing seizures after 2 trials of 2 medications, we need to be thinking that could you be a candidate for epilepsy surgery? Now that is it's a big idea for a lot of people, and the next step, of course, is, and Dr. Katak will get into this, is video EEG monitoring, where we bring you into hospital. And who has been through video EEG monitoring? Can we have a show of hands? Do we have? Expected more than that, a few more than that. But you come into hospital, as Michigan Medicine was telling us, and we stop your medications and we record your habitual seizures. So, but sometimes I think the best way because, families will say, "Doc, it's brain surgery. You're going to break open my skull," and she's only 2 or 3, and do we really want to go there? She's so young. And I think one of the ways of thinking about video EEG monitoring, what I tell my patients, it's a way of learning more about your epilepsy. What is your seizure type? Is there another medication which might help you better? Or could you be a candidate for epilepsy surgery?
Thank you. We'd love to let our community know what kind of process they might undergo if their doctors are considering surgery. So can you share some of the most common diagnostic tests that are used in pre-surgical evaluation, and how do these tests help you and the patient decide what surgical approach would be best?
So as Dr. Constantino alluded to, the very first test, or the most important test I would say, is to undergo the video EEG monitoring. Now, the first thing is that we have to be sure that we are dealing with epilepsy, because a lot of people may have spells that may mimic seizures associated with epilepsy, but they may not be. So this epilepsy monitoring unit admission, which is an elective admission where there are trained physicians, nurses, and technologists who all work together, and we try to capture these episodes on video EEG. So this is for a diagnostic purpose, as well as what kind of further options we have. If the seizures are coming from one area of the brain, are they coming from 2 different areas of the brain? Are they coming from all over the brain? So that determines what's the next step. The other standard of care is getting a very good high-quality MRI of the brain. Now, this is a specialized MRI, which is a 3 Tesla, high magnetic field, and this is looking at certain parts of the brain much more closely that are typical culprits for seizures. And that will help in determining the etiology or the cause of the seizures. Now, once we go through these 2 testing, and depending upon the history, then we determine whether any further testing is required. That may individualize to MEG scan or PET scan, but these are tests that we do only after we first go through these standard of care first 2 tests. Okay?
Yes, so MRI is a very important investigation and is probably the linchpin, because especially in pediatrics, if you look at successful epilepsy surgery in childhood, the vast majority of surgical candidates have a lesion on the MRI. So 40% will have what's called a focal cortical dysplasia, which is it's an area of the cortex. When the brain is inside mommy's tummy, we get the cell forms like a tube, and then you get migration, like waves on a beach to form your 6-layered cortex, one on top of the other. And sometimes there's a glitch in the way that your genetic programming is, you'll see an area that we call a focal cortical dysplasia. So when we look at epilepsy surgery in childhood, so pediatric epilepsy surgery is different from adult epilepsy surgery. We don't see as much temporal lobe epilepsy. We don't see as much hippocampal sclerosis, which is the hardening of the temporal lobe. We tend to see more these developmental lesions of focal cortical dysplasia 40% of the time. 20% of children, I think we heard from someone in the audience who had a tumor removed. So sometimes it can be something that's called a neuroglial tumor, something which are benign tumors which are potently epileptogenic. So MRI, especially in young children, can fail to detect subtle dysplasias, and especially under the age of 2, because under the age of 2, the brain is not myelinated, and so these subtle regions of malformation sometimes are hard to see or can be difficult to see. So we often recommend repeat MRI after the age of 2, and as Dr. Katak said, we want a high resolution MRI, a 3T, we want special sequences, we want thin cuts, and those can help detect one of these anatomic lesions.
Thank you. And Dr. Ayer, some questions for you as well. One of the most common types of epilepsy surgery is temporal lobe resection for those with temporal lobe epilepsy, and I know some people here have had that procedure. Can you share with us what is resective surgery, and for an individual patient, how do you decide how much brain tissue to remove?
Absolutely. For so long, a resective surgery or a procedure in which we remove a portion of the brain has been the gold standard for treatment of epilepsy, because we know that when we have a clear abnormality that is seen on an MRI, such as hippocampal sclerosis, as we've been discussing, and the epilepsy, the seizures that are recorded are clearly mapped to that region, that when we remove that region of the brain, we are likely to see 70% seizure freedom. And so that has always been our goal. If we can find an area that matches up very tightly between an abnormality of the brain and in that is clearly the area causing the seizures, if we can remove it and remove it safely, then that is what we want to do. Now, how much tissue and whether we can do that depends greatly on where that is. So for somebody who has seizures in the temporal lobe, oftentimes by the time they are refractory, meaning that they're continuing to have seizures, that tissue, in terms of its normal function, which is related to memory, has shut down, and the other parts of the brain have picked up that activity. And so we will do additional testing, such as a neuropsychology evaluation, to see where that function is. Sometimes we need to do some testing to see where language function is. And if it's really true that part of the brain is doing nothing but causing seizures, then removing that is fairly straightforward and makes sense. Unfortunately, there are times when we can't do that because the area that's abnormal or causing seizures is related to a level of function that we want to preserve, say speech or movement or sensation. And so in those situations, we have to determine how closely the seizure area is to something that controls function we want to preserve, and whether we can remove some portion of it without interfering with normal function.
And when someone has temporal lobe resection, what range of outcomes might they experience? And what could their treatment continue to look like after the surgery?
Sure, absolutely. So as I mentioned before, in those clear cases where somebody clearly has an abnormality of the temporal lobe, the seizures clearly map to that location, and all the other testing goes along with it, then we are expecting a 70% seizure freedom after that surgery. We have learned many things over a long period of time, including which that going to zero medications after such a surgery is not in individuals' best interest. Generally, people can come down significantly on their medications over time, but we typically want to keep them on generally at least one medication, I would say, because we know that an individual who's had epilepsy for a while, that their brain is just more prone to it, and we want to stop the process of other areas of the brain now generating a new location, a new source of seizures. But that is certainly something that we do worry about and monitor, and so ongoing follow-up with your neurologist is needed.
Yeah. And speaking of that, Dr. Constantino and Dr. Katak, in follow-up visits with people who have had resective surgery, what do you seek to observe and evaluate in your patients? And we know obviously you're going to look for possible seizures, but with that, are there any kinds of complications you might want to track, maybe cognitive symptoms or mental health symptoms?
I think, as you mentioned, the most important thing is to see whether they had any breakthrough seizures after the surgery. If the seizures were different from the one they had before the surgery, do they have the big seizures, the grand mal seizures? And then during the visit, we also do a full neurological examination, looking at the cognitive functioning, the language, the visual field, depending upon what type of surgery they had, and the motor and sensory function. And then in addition to that, we also usually do a neuropsychological testing, which is like multiple hours of cognitive functioning that we compare to the baseline that was done before the surgery and see if there was any difference, and if there are things that we can improve by cognitive rehab. So those are the kind of things that we do.
Thank you.
So,
And,
sorry,
go ahead.
I was just going to say it. So yeah, I'll go back to my mentor, Peter Silberstein. He was my mentor that I'd asked why should I do pediatric neurology? And then I know I went back to Boston Children's, and I came back to Perth, and I was the young attending, and I thought I was really good. I knew a lot more than Dr. Silberstein about epilepsy. And I remember walking under the tunnel. There was a Princess Margaret Hospital had a tunnel between the hospital and the parking lot. And Silp said to me, he was shaking his head, and he was like, Jules, you know, it's more than just the seizures. And that's sort of processed. And then a year or two later, because I think, as Jamal is maybe learning out, is your life really doesn't begin until you start your training. Until you finish your training and you start working and you're seeing lots of patients and they're relying on you and you're doing your best and they're doing their best. And then, you know, it's like, well, you know, maybe 5 or 10 minutes is the seizure count, right? How many seizures, what type of seizures? The rest is what's going on at school. How's your attention? How's your behavior? How's your mood? How's your sleep? And that really is what a lot of families struggle with. It's more than just the seizures. So when we're seeing a child after epilepsy surgery, yes, what we want is we want seizure freedom, we want seizure improvement, and the question becomes how much seizure improvement, because, you know, there are surgeries that we know are with a good success rate. So temporal lobectomy, if you have measles sclerosis, if you have a hemispherotomy and you have a structural lesion, we can expect 80, 90, 100% seizure freedom rates. Other epilepsies, the extratemporal, you know, the way an epileptologist or an epilepsy specialist thinks, we sort of subdivide epilepsy into temporal, where we expect a good outcome, and extratemporal. And maybe in the extratemporal, we're not going to see as good a seizure outcome. So not only am I looking at what's happened to the seizures, because if you look at measures of improved cognition, improved mood, improved behavior, improved quality of life after a receptive surgery, I mean, seizures are an important part of that equation. Meds are an important part of the equation if we can cut back some of the meds. But as an extra boon, as a pediatric epilepsy person, is what do I want to see? I want to see developmental gains. I want to see you advancing developmentally. I want to see your behavior better. You know, not tantrums. I want to see your mood better. So these are things that we would evaluate, and there's you know, instruments that can help you evaluate those things. But so that's the sort of thing that we're looking at as we follow someone after surgery.
Thank you. I know a lot of people can relate to that as well, and it's so important to treat the whole patient and the whole life, and we love partnering with you all in that as well. You mentioned a little bit about this, Dr. Constantino, but we know some forms of resective surgery take place outside of the temporal lobes, and maybe perhaps resection in the frontal or parietal or occipital lobes, and sadly those have had lower success rates than temporal lobe resection. So Dr. Eyre, I'm wondering if you can talk about some of the challenges of performing resective surgery outside of the temporal lobes, and what are some of the risks involved?
Yeah, sure. So they are similar in the sense that we are looking for a location where the highest chance of finding or of achieving seizure freedom is when there is a clear abnormality of the brain tissue itself, whether that be a dysplasia, as Dr. Constantino mentioned, a tumor, a scar, a something, and that is clearly what is causing the seizures. And removing that gives us the highest rate of seizure freedom. So unfortunately, in areas outside of the temporal lobe, we do have situations where those match up and we can have really great success, but we also have situations, for whatever reason, the parietal lobe and the occipital lobe don't, those surgeries in those areas tend not to be have a rate of seizure freedom as they do in the temporal lobe, and then the frontal lobe is sort of slightly behind that. I do think part of that is because in those other regions, we get very concerned about how much tissue to resect and not wanting to affect other people's or the rest of their functions. So that's when we start thinking about other ways we can potentially affect the seizures and improve them, and sometimes even just stopping the spread of seizures. So as Dr. Constantino mentioned, the hemispherotomy There's something called a corpus callosotomy. There's some procedures where we know that it's really the spread of the seizure and when it starts getting to broader areas that is where the dysfunction and where the serious impact on one's life becomes. And so sometimes just even a disconnective procedure, such as one of those two areas where we prevent the rapid spread of a seizure from one part to the rest of the brain, and have the diseased brain sort of isolated a little bit, that can be effective.
Yeah, thank you. And of course, another surgical process is laser ablation. So rather than removing or disconnecting
Yes.
brain tissue, this surgical technique involves destroying seizure-causing brain tissue. So I'm wondering if you can describe the technology and techniques involved in that kind of surgery, and what are some of the advantages or disadvantages?
Absolutely,
Yeah.
yes. So in full disclosure, there is an ongoing clinical trial called the SLATE trial, in which laser ablation for temporal lobe epilepsy is being very strictly studied. We also are using it outside of the trial. Henry Ford is part of that trial. But part of the reason for the trial is to be able to truly understand all of the risks and benefits in a controlled way of doing the laser procedure. So the advantage of a laser procedure is that it is a very small opening. It's literally like one stitch size, less than a centimeter opening, and a drill in the small little opening in the bone where we can pass the laser into the area where the tissue is abnormal. So this is being studied in temporal lobe epilepsy. There's been in children, there are epilepsy caused by hypothalamic hamartomas. This has been shown to be very successful in those individuals, and also in some cases where there is, say, a cortical dysplasia or other abnormality, even in seizures related to tumors. So we place the fiber into the center of the area that we wish to ablate and turn on the laser. The laser then heats up and destroys that abnormal tissue. We're watching it in real time in an MRI to monitor it and to protect other areas of the brain. So the advantages of it, obviously not having as large of a resection or surgery, opening, recovery, all of that has been greatly beneficial. And we are, part of the study is to understand whether or not we might have fewer cognitive side effects of undergoing that resection, of undergoing a laser versus undergoing an open resection.
That's so interesting, thank you. Of course, alongside anti-seizure medications, some patients may be candidates for neuromodulation devices like the VNS, vagus nerve stimulator, or the RNS, responsive neurostimulation, or the NeuroPace, or DBS, deep brain stimulation. I'm just curious if anyone has a neuromodulation device, if you might share that with us and we can kind of see that. So yeah, we've got some people here with those. Dr. Katak and Constantino, how do these neuromodulation devices work, and what is the process to be evaluated for these? How are they surgically implanted?
So as we were discussing before, that the first step is the video EEG monitoring. Now, if we find out that the seizures are coming from an area of the brain that is important for language or motor function based on our pre-surgical workup, which will mean that we cannot safely remove that abnormal brain tissue, because then we risk language or motor function or significant memory. In those cases, we can consider neuromodulation devices. Then there are other cases where we find that the seizures are coming from more than one area in the brain, like meaning coming from 2 areas of the brain or 3 areas of the brain, or they're coming from all over the brain. In these cases, we consider these neurostimulation or neuromodulation devices. So these are devices basically that give electricity to suppress the seizures. Now, there are 3 main devices we talked about. The least invasive of them all is the VNS, or the vagus nerve stimulator, which is placed under the skin on the chest and connects to the vagus nerve on the neck. And it gives electrical current, and it has been shown per different studies that 5 out of 10 people who get this device have significant reduction in their seizures. So that's pretty significant. We consider it palliative because it does not usually stop the seizures completely compared to the surgery resection, where we remove the tissue, but they significantly reduce. And then the other 2 devices, the responsive neurostimulator or the deep brain stimulator. The responsive neurostimulator is a device that is basically an electrode is placed in the area where the seizures are coming from, and then it's connected to the generator, which is placed into the skull. And basically, it's like a pacemaker where it detects abnormal brain activity, and then it gives electricity that you don't feel it, but it stops the seizures. And that has shown that 7 out of 10 people who get that device have significant reduction in their seizures. And then the deep brain stimulator is the third device, which was also used for Parkinson's disease, where we target certain areas in the thalamus, and that also gives electrical current to stop the seizures, and have also shown similar kind of results as responsive neurostimulator. So all these devices are really good tools that slowly have become part of the surgical care that we can offer when someone may have had a surgical workup in the past and they were told they're not a surgical candidate, but now we have these different devices that can be offered and have improved the quality of life significantly.
So yeah, I think you know, the brain modulation device that I have the most experience with, which has been around the longest, is vagus nerve stimulation. And you know, I think to think about vagus nerve stimulation, I think we want to have a drug-resistant epilepsy. We want to have an epilepsy which we think is not amenable to surgery, because if you are a candidate for surgery, you tend to do better with surgery. And you may not be a candidate for surgery either because we can't localize the seizures. They're spreading so quickly, and there's some other tools that we can use sometimes to localize seizures, which we haven't talked in depth about, things like PET and ictal SPECT. So if we can't localize, or if the area of that generates the seizures, what we call the epileptic genic zone, if that overlaps or is in close proximity to what we call functional or eloquent areas of the brain, and usually we think about language function. We don't want to operate somewhere near your language areas of your brain, because we want you to be able to talk after your surgery, and we want you to be able to move. And so if there's a close proximity of the epileptic focus to important cortex, that might move us away from resective surgery towards neuromodulation. So vagus nerve is actually quite interesting, and how and why it works, no one really knows, but the vagus means the wanderer. So it's the longest nerve in the body. So it starts in your brain and it goes all the way down to your gut. And you know, when I first started doing this, the number of moms would come to me and say, you know, doc, when he gets constipated, his seizures are worse. And has anyone come across that? And I was like, I wasn't taught this in medical school, but I've heard it enough times, and that's the vagus nerve affecting the seizure. So somehow the vagus nerve, so really how vagus nerve works is it's a bottom-up approach. So the vagus nerve goes up towards the brainstem in a bottom-up way, and it's connected. There's a nucleus in the brainstem, and that projects to areas, to the thalamus, to the limbic system, which is the loop, which includes the temporal lobe, to the cortex, and also to brainstem nuclei. So it alters the chemistry of the brain and the locus. So all these upstream effects help with time modulate the seizure generation. So that's the main way that the VNS works, is that you know, we can program it different ways. You know, usually we send a low volume pulse. Sometimes it can be every 5 minutes or every 3 minutes, or sometimes I'll even do it very rapid cycle, every 1.1 minute, every 1.8 minutes. Of course, that's going to chew up your battery more quickly. But that stimulation every few minutes, with time, it sort of soothes the brain waves, you see, and with time, you will see a seizure reduction. And that's the main way that vagus nerve stimulation works. Now, I think over the last few years, we've seen newer models. We've seen what's called the Sentiva and the Aspire. And this is an attempt to change modulation from what's called open loop to closed loop. So open loop stimulation means just the way VNS used to be, was we'd send a signal every 3 minutes. I don't know what's going on in the brain. Just send it along, and with luck, it's going to stop things, right? Now, NeuroPace is different because there's a device which will detect the seizure and then will curtail or stop the seizure, you see? So the new models of VNS, one of the first things that can happen when you have a seizure is your pulse increases. There's a tachycardia, and it's a sudden increase. So the VNS is it has a cardiac detection device, a pulse detection, and that's a surrogate for a seizure. So, your pulse has suddenly gone up. I'm going to program it to send an extra stimulus to the brain, and maybe that'll give us an added benefit. And that may be helpful for, particularly kids or individuals with impairments who cannot pass the magnet. And then, of course, the third way the VNS works is by passing the magnet. Now, everyone gets very confused about how should I pass the magnet, and how quickly should I pass the magnet, and how often I can pass the magnet. And the number of calls we get is like, can we do it twice? Can we do it 3 times? Do we do it just once? Do we do it quickly? Do we do it slowly? And actually, it's not very difficult. You just very slowly swipe it up, and you just need to do it once. And if it's going to stop the seizure, it's going to stop the seizure. And people get very, just once and slowly, just a slow pass. Just a slow
Can
pass.
all practice that.
And it is effective. I think when VNS first came out, sometimes we'd see kids that we didn't impact the seizures, but it affected behavior. These are kids that were having tantrums, all day long, and so it has psychotropic benefits as well. And just one more thing I'll say about VNS, and maybe before the other interesting thing is it is effective, and it's not curative. Only 10% of people become seizure-free, but it is a battery device, and 50% of people get a 50% reduction in seizures. But when the battery goes flat, the wires in your neck, they always have to stay in. But when your battery goes flat, you sort of have to make a decision. Do we replace the device or do we remove it? And I think my experience is maybe about 2/3 of families will tell me, Doc, I think it's helped enough that I want to have the battery replaced.
Yeah, and speaking of that, I know it can vary from patient to patient, but Dr. Eyre, what was the typical battery life for some of these commonly used neuromodulation models, and how extensive is the process to replace that? What happens with that?
So it varies quite a bit depending on sort of the device, and for every single electrical device, it is just like your phone, right? So if you're on it all day long, you're going to have to recharge it earlier than if you set it down and you didn't come back and pick it up for several hours. So the more it is putting out, the more often a battery needs to be replaced. And of course, every time they come out with a new generator that has the new model, they always say this one lasts so much longer. Whatever it is the company says, discount it by a couple of years. It's just a reality. I'd rather somebody get much longer out of a battery than be disappointed that they didn't make it to 8 or 7 years or whatever it is. So on average, we're probably replacing batteries about every 5 years, even across all the different devices. And for a VNS or a deep brain stimulator, that is just an incision under the skin in the chest. When it comes to the responsive stimulation, that device actually goes into the skull, and that requires an opening in the skin. Again, it is just an opening in the skin. You do not have to go deeper than that. It is still an outpatient surgery, but it just feels a little differently because we're going back to the scalp rather than to the chest skin. But if I could take that as an opportunity to give a little bit of background on how it is that we pick between these different options. because electricity is not just electricity. So VNS, which is the oldest of the technologies, it is very useful because there are so many situations in which somebody isn't immediately clearly eligible for brain surgery, and we might need to do some investigation, even sometimes invasive investigation, and a VNS is the lower risk and also can be quite effective option. And so it's not unusual that we would start with that type of implant. However, for other situations, it is really beneficial. And if you look to go to the stimulators that go into the brain, and that's because those have been shown to be more effective. And I have patients who have both and have both running. So sometimes there is something about ongoing stimulation to the brain that is impactful and helpful for seizures. So the difference between the RNS, as was mentioned, this is closed loop. It means that it has to be, the electrodes have to be sitting in the area or very, very closely to the area where the seizures are starting, because it's recording that information and it's picking it up faster than you can compute that it's coming to you physically, and it snaps that seizure by giving a burst of electricity back into that area to sort of shut those nerves down. So we need to know where the seizures are coming from in a pretty good sensitivity to know where to put that. And so sometimes that means we need to do a little bit more mapping. That can be something called phase 2. It can be called a stereo EEG these days. Phase 2 used to be where we would have to make a big opening in the skull and put just sheets of electrodes all over the brain in order to map the seizures. These days, we far more often do something called stereo EEG, which is a series of individual kind of poke holes in the skin with thin wires, like a piece of spaghetti, that go into the brain tissue that we can use to map the seizures. And if we can find a very distinct area of seizure focus, then that gives us an opportunity sometimes either to remove that area or to actually put a responsive stimulation in. For some cases, as was mentioned, we can't find it, or there are too many areas that are firing, and we need to do more of I call it a circuit breaker type of stimulation, and that's the DBS. So we're putting it into a central area of the brain that's sort of like the circuit breaker in your house that is firing off to kind of cut off those seizure electrical signals to reduce overall the number of seizures. And I apologize, I am on call, so I need to answer this.
Yes, we support that, and we're grateful for you being present in that way. So some patients are going to have some common fears when pondering surgery, also their families. And when you mention this as an option, what are some of those common concerns, and then how do you address those?
So it's whenever I mention this epilepsy surgery to my patients, it's a very common fear that isn't surgery the last resort or the last option. And it's reasonable or understandable that brain surgery does provoke fear and anxiety. But what I try to tell my patients is that we have to weigh the risk and benefit. First of all, when we do this surgical workup, this is a long process. Just because you committed to doing the surgical workup, you're not committing to actually getting the surgery where you remove the brain tissue. So while we're getting all this workup, we will, during this process, update you what we think are the risk and benefit. And if the epileptologist or the surgeon thinks that this is more riskier than the benefit, then we will let you know, and we won't go ahead with it. So that's one thing. The other thing is that we have to understand that if we maintain the status quo, meaning continue to have seizures, that itself has much more risk. So studies have shown that people with epilepsy, if they continue to have seizures, especially the one which are the grand mal or where the whole body is shaking, they are much more likely to die prematurely, what we call SUDEP, sudden unexpected death in epilepsy. That's much more likelihood if someone continues to have seizures. Then their quality of life, their social, like their job, they cannot drive, they can collapse and injure their spine, dislocate their shoulder. So all of those risks are there. Now compare that to the surgery the surgery risks are very minimal. Majority of times, these are incidental findings, and they do not lead to any kind of significant impairment. So that's one thing I tell the patients. And always remember, you have to be comfortable, the patient has to be comfortable and confident before we proceed with the surgery. So this is a long process. There's a lot of different tests that we do. And eventually, when we both come to a consensus, and this is not one person deciding this. So whenever there's a surgical workup, after we do the whole workup, there's a multidisciplinary conference where all the epileptologists of the group, the neurosurgeon, the neuroradiologist, the neuropsychologist, we decide in a multidisciplinary conference where we discuss the whole case and then come to a consensus. And that consensus is discussed with the patient, and the risk and benefit are provided, and then the patient can make more of an informed decision.
Yeah, so there's certainly barriers to thinking about and accepting or making a decision to proceed to epilepsy surgery. I think not only, fears of cracking open the skull, operating on the brain. She's only 2, and I think, I think from the pediatric point of view as well, I think a lot of parents struggle with, the decision-making process because, it's not me. I'm not making a decision for me. I'm making a decision for someone else, and that's just so much more difficult, isn't it? And I just in preparation for this, I looked up a very interesting article, actually from I think it was UCLA rather, and they looked at the time from the onset of the epilepsy to when epilepsy surgery was actually carried out. If you look in the adult literature, the average age of temporal lobectomy, which is the best epilepsy surgery, which is potentially a curative epilepsy surgery, is in your mid-30s. If you ask most people, when did your epilepsy start? They will tell you, well, ever since I've been a teenager. So we're waiting 20, 30 years to treat temporal lobe epilepsy, which is a surgical disorder. And how's that going to change your life? I mean, you haven't been able to drive, it's been hard to get a job, there's the stigma that comes with epilepsy. So that's the adult side. But they asked families, and these were structured interviews with about, I think there were 37 parents, and how did you come to that decision to proceed to epilepsy surgery? And the way they sort of broke it down was, firstly, the first step is processing. How do you process the impact of seizures? I mean, I'm sure those of you that have children with seizures remember that first seizure. I always ask about the first seizure because we remember it. And then the second seizure, because you can look at epilepsy both ways. You can look, when it's already established, but when it begins, that's a tough time as well. So you've got to process and understand, and there's almost like a grief, that you have to go through. And then the next step is navigating, okay? I've processed the issue. Now, how do I navigate? How do I get to find the right doctors? One family said they had to see 5 pediatric neurologists before they could see someone that could actually help. One of the parents says, well, one of the doctors I saw, and I hope I'm not in California, so I don't think it was my office, but the doctors were rude and they were unkind, and that's, maybe, they did a survey of, and this is actually in Michigan with Dr. Spanaki, and they asked neurologists, they said, when is the right time? Can you have epilepsy surgery when you're less than 10? And I think 60 or 70% of neurologists said no. So again, there's that lack of knowledge. So we have processing, we have navigating, becoming your own epilepsy expert, and self-managing. And then there's the decision making, and those sort of one leads to the other. You know, how am I going to go? Am I going to time? and then the next thing. So we go from processing to navigating to decision making, and then the final step is facilitation. And what they talk about is, and this is where the Epilepsy Foundation can help us, where our psychologists can help us. You want a champion, right? You want someone that's going to be on your side, that's going to help you work towards this very difficult issue. You want a team of doctors. You want a multidisciplinary team that understands epilepsy. And then you want a community. You want a support from the community. And they asked families, they said, would you be, someone that's already done the epilepsy surgery, would you be wanting to talk to another family? So that, and a lot of families, every family says, yes, of course I want to help someone else on that journey. So those are the steps.
Thank you so much. And just so grateful for your expertise today, your stories, your kindness, your information. And so please join me in thanking Drs. Ayer, Katak, and Constantino. And now it is time for some Q&A. So looking forward to your questions. Please keep in mind our doctors today cannot give medical advice for specific individuals, but can certainly answer much generally. And so I'm wondering if you have a question, please raise that hand high and a microphone will be coming to you. And so there's a question right up here. So a microphone is coming. Great.
So this question is for you, Dr. Jules. Has anyone ever walked up to you and called you Richard Pryor?
Say again?
Has anyone ever walked up to you and called you Richard Pryor?
No.
Because you look like him.
I'll have to find out what
You've
he
ever
looks-
heard of him?
I think
Thanks,
I heard
David.
it.
He was the guy on Night Court.
We've got a question in the back. Thank you.
I'm gonna stand up. Dr. Constantino, you used to be my daughter's doctor. I don't know if you remember Nicole Mudge. I'm wondering, Dr. Elisavich did the multiple subpial transection surgery on her. Are we not doing that surgery anymore?
Yes, so I think multiple MST, I think it's probably historical.
Yeah, it's become, so even in the decade plus that I've been doing this, started out doing that much more frequently earlier. As we've had more tools, the MST was always sort of the backstop. I can't take this part of the brain out because it is an area that is a concern for function, and so we make the cuts in the tissue in order to prevent the seizures from spreading to other areas, sort of that disconnection theory, and it did help, but the impact of that and how effective it is has been kind of overpassed by the new technologies with stimulation that don't have the same risks of causing loss of function.
That's what I was wondering, because she's been seizure-free.
That's wonderful. That is
Great news.
That is wonderful news.
Good. And over here, please.
Is there, trying to figure out how to ask this quickly, an MRI is not showing over 100 grand mal seizures. Is there a reason for that, and can you make a recommendation on what steps to take? Is it the wrong person reading it at Henry Ford?
So MRI is looking at the structure of the brain, and it depends upon what's the cause of the seizure. So if the seizure is coming from abnormality in a small area of the brain, what we call focal cortical dysplasia, which is a malformation that happens from development. So that can be picked better by getting a higher magnetic field MRI. But a lot of times the MRIs are normal because either the abnormality is very microscopic that cannot be seen with a naked eye with MRI even, or at times it's a generalized epilepsy, like the seizures are coming from all over the brain. In those cases, the structure of the brain is intact. It's more about the electricity, and that can be picked by EEG. So the MRI would not pick up grand mal seizures. It would be the EEG. If it's hooked up while the patient is having seizure, that's basically records it. So MRIs looked at the structure or the cause of the seizures, while the seizure itself are picked up by the EEG.
EEGs can detect seizures. There's never been a seizure that has happened in front of a doctor. They're all nocturnal. But EEGs can record past
So the
seizure
EEG
activity?
Yeah. So the EEG, first, if you monitor for longer periods, sometimes, like as we discussed, we admit them to the hospital for multiple days, record the sleep portion as well to capture the nocturnal seizure. Sometimes we have to wean off the seizure medication to provoke a seizure. In addition, a lot of people who have epilepsy will have something abnormal in their background brain waves, even when they're not having seizures. We call that interictal discharges. So those are not seizures, but those are clues to us that there's a sparking activity in the brain that gives the clue that this individual patient has risk of seizures from this area of the brain. So it will not record the seizure itself if you don't have a spell, but it will record a lot of times other abnormalities if you record enough period of time. Because EEG is a snapshot of the brain. So if you do for 30 minutes, you may not record anything. If you do for 6 hours, you have a better chance. If you do for multiple days, you will have a higher chance to record something.
Well, and even with that, I will say there are some seizures that if they're coming from very deep areas and that's known in sort of frontal lobe and insula area that are very hard to capture. And, you know, I had a patient years ago that had nocturnal seizures, was getting up and severely injuring himself because he was running all over the house with these seizures in his sleep. And the EEGs were all negative, and we had this conversation, and, you know, gut check for me as a surgeon to say, I'm sorry, you want me to put electrodes in somebody's brain when I can't see anything and the EEG isn't telling me where to go. And sure enough, they were frontal lobe seizures. We did a resection. So, and we might, sometimes we don't find them, but sometimes it does actually, if you get to that point, might take invasive monitoring to capture.
And sometimes also we can do other testing while the patient is hooked up to EEG. We call it ictal SPECT, where we inject a dye and that goes to the brain that lights up in the area where the seizure is coming from. If we can capture the seizure, patient is having a seizure, we can inject the dye. And then there's also called a MEG scan that also looks at the deeper structures of the brain much more closely. So depending upon the semiology, meaning how the seizures are presenting, we can do further workup to pinpoint where the seizure is coming from. And then eventually it may require intracranial monitoring where Dr. Ayer might have to put electrodes inside the brain to record the seizure itself.
Sometimes it's not always some physical things. There's the nerves themselves can fire abnormally and structurally look okay. And if they structurally look okay, you're not going to see an abnormality on an MRI and imaging.
Thank you. We have time for one more
Thank
question.
you. We have a couple more.
Yeah,
We have one here and then one here at least.
Okay, I
Okay.
just want to say that I do have an RNS in my head, and it has been completely life-changing for me on a positive way. And before they put it in, they did an MRI, and I'm kind of claustrophobic, so they gave me some medication to help me relax. But they later wanted to do another one without any medication to relax. Does the medication that makes me relax kind of like show the brain differently?
On the MRI itself?
Like
So
if I was
it's-
on the meds and I'm a little loopy, will it show differently if I wasn't a little loopy?
Not for the most part for structural. If somebody is in active status epilepticus, there are some signals that might be brighter on an MRI that would not be as bright if they were in between seizures, but the overall structure of the brain generally still looks the same.
Thank you. We're going to do one more question over here, but please keep in mind you can speak to the doctors afterward as well. And I'm so glad that they can answer those questions for you. Yes, Dave Trojan.
The ablation surgery sounds extremely interesting. I had a cardio ablation, and is it basically snipping a wire for the neural pathway to that affected area of the brain? Is that what that is?
It's actually basically burning the brain tissue.
I'm sorry, I didn't.
It is burning the brain tissue. So
Right.
it is actually destroying, and the one nice thing about the laser is it tends to form to areas of abnormality, and so it allows us to basically focally take an area that's abnormal and zap it.
And you can do that more than once?
Mm-hmm.
Yeah, thank you so much. Let's thank Dr. Ayer, Dr. Katak, Dr. Constantino. I'm so grateful.